As a first-year internal medicine resident, you are well versed in the signs and symptoms of DKA and HHS, two serious complications that can arise in patients with diabetes. One day, a patient is admitted to the hospital with symptoms of polyuria, polydipsia, recent weight loss, nausea and vomiting, and signs of significant dehydration. As you examine the patient, you notice neurological abnormalities, altered mental status, lethargy, and even coma. You also notice other neurological examination abnormalities such as blurred vision and weakness. As you speak with the patient, you learn that he has a history of diabetes and you immediately assess him for DKA and HHS. You know that patients with known diabetes who present with nausea or vomiting should be immediately assessed for these complications. As you examine the patient further, you notice specific findings that indicate DKA, such as a rapid onset of symptoms in less than 24 hours, in contrast to HHS, abdominal pain, and a fruity odor on the breath from exhaled acetone. The patient is also hyperventilating, taking long, deep breaths known as Kussmaul respirations. You quickly order lab tests and treatment for DKA, knowing that prompt intervention is crucial to preventing serious complications and saving the patient's life. As a first-year resident, it is a challenging but valuable learning experience to see the signs and symptoms of DKA and HHS firsthand and to be able to effectively diagnose and treat the condition. You begin by checking their serum glucose levels to confirm the diagnosis. Next, you order a basic metabolic panel to check for serum bicarbonate, anion gap, electrolytes, and renal function. You also check for the presence of ketones in the patient's urine and serum. Standard urine dipstick assays can detect acetoacetate and acetone, but not beta-hydroxybutyrate, so you also order a serum beta-hydroxybutyrate test. To evaluate the patient's acid-base balance, you order a blood gas analysis for pH. As part of the diagnostic workup, you order an HbA1c, complete blood count, and electrocardiogram to rule out any underlying causes. You also perform an infectious workup. If the patient has type 1 diabetes and presents with hyperglycemia, ketonuria, and high anion gap metabolic acidosis with decreased bicarbonate, you diagnose them with diabetic ketoacidosis. On the other hand, if the patient has type 2 diabetes and presents with hyperglycemia and hyperosmolality, you diagnose them with hyperosmolar or hyperglycemic state. You should also be aware of the laboratory findings in hyperglycemic crises. In DKA, patients typically present with hyperglycemia, high anion gap metabolic acidosis, and ketonuria, ketonemia. In contrast, HHS patients present with hyperglycemia, hyperosmolality, and dehydration without ketonuria. It's also important to know the diagnostic criteria for DKA and HHS. DKA is characterized by glucose greater than 600 milligrams per deciliter, with about 10% of patients being euglycemic. Glucose greater than or equal to 250 milligrams per deciliter, bicarbonate over 18 mg per liter, anion gap elevated greater than 10 mg per liter, moderate large urine ketones, and glucosuria. HHS is characterized by glucose greater than 600 milligrams per deciliter, bicarbonate greater than 18 mg per liter, normal anion gap lesser than 10 mg per liter, negative or small urine ketones, and glucosuria. When evaluating the patient's electrolytes and renal function, you should be aware that hyponatremia is common in both DKA and HHS due to hypovolemic hyponatremia and hypertonic hyponatremia. You should also check corrected sodium for hyperglycemia. Potassium in DKA is normal or elevated. Despite a total body deficit, magnesium levels are typically low. Phosphorus levels may be elevated despite a total body deficit, and BUN and creatinine are often elevated. For anion gap calculation, use the measured serum sodium concentration rather than the corrected serum sodium concentration. Additional diagnostic workup may include an HbA1c, urine pregnancy test, a CT head, toxicology screen, CBC with differential, serum lactate, 12-lead ECG, abdominal imaging, serum lipase, serum transaminases to rule out infection, myocardial infarction, and pancreatitis. Pregnancy and SGLT2 inhibitors can cause euglycemic DKA, high anion gap metabolic acidosis with normal or near normal glucose. Lastly, you must be aware of the severity of DKA and HHS, which can be determined by the arterial pH, serum bicarbonate, anion gap, and mental status of the patient. For DKA, mild cases typically have an arterial pH above 7.24, serum bicarbonate between 15 to 18 mg per liter, anion gap greater than 10 mg per liter, and the patient is alert. Moderate cases have an arterial pH between 7.0 to 7.24, serum bicarbonate between 10 to 15 mg per liter, anion gap greater than 12 mg per liter, and the patient is either alert or drowsy. Severe cases have an arterial pH below 7.0, serum bicarbonate below 10 mg per liter, anion gap greater than 12 mg per liter, and the patient is stuporous. In case of HHS, mild cases typically have an arterial pH above 7.24, serum bicarbonate between 15 to 18 mg per liter, anion gap greater than 10 mg per liter, and the patient is alert. Moderate cases have an arterial pH between 7.0 to 7.24, serum bicarbonate between 10 to 15 mg per liter, anion gap greater than 12 mg per liter, and the patient is either alert or drowsy. Severe cases have an arterial pH below 7.0, serum bicarbonate below 10 mg per liter, anion gap greater than 12 mg per liter, and the patient is stuporous. Both conditions are managed by restoring intravascular volume, repleting water and electrolyte deficits, repleting insulin, and treating the underlying cause. The initial steps in management include following the ABCDE approach, assessing airway, breathing, circulation, disability, and exposure for urgent diagnostics, such as point-of-care glucose, BMP, and blood gas analysis, as well as assessing the patient's volume status. The principal interventions include fluid resuscitation initially with isotonic saline, potassium repletion if the potassium level is lesser than 3.3 mg per liter, insulin therapy once potassium level is greater than 5.3 mg per liter, and IV sodium bicarbonate for severe refractory metabolic acidosis. It is important to identify and treat any precipitating causes, such as sepsis, and to consider an endocrine consult and ICU admission. The goal of therapy is the resolution of ketonemia and acidosis, closure of the anion gap, and DKA, and of hyperglycemia and hyperosmolarity in HHS. Monitoring includes hourly vitals and mental status, hydration status, POC glucose every 1 to 2 hours until blood glucose is lesser than 250 milligrams per deciliter, and hourly blood glucose readings are stable for at least 3 hours. Then decrease monitoring to every 2 to 4 hours, serum osmolality every 1 to 4 hours, blood gas and BMP with electrolytes every 2 to 4 hours. Monitoring of volume status, serum glucose, serum electrolytes, and acid-base status at regular intervals is essential. Disposition includes admission for all patients with HHS and most patients with DKA. ICU admission should be considered for patients with persistently altered mental status or hemodynamic instability, severe electrolyte imbalance or persistent acidosis, or underlying critical illness like sepsis or MI. Discharge may be considered for patients with mild DKA and resolved anion gap acidosis, no concerning precipitating cause, toleration of oral hydration and nutrition, and ability to adhere to discharge instructions, including outpatient follow-up. Pregnant patients with DKA should be assessed by an endocrinologist and obstetrician because of the potential for a high-risk pregnancy. In terms of fluid and electrolyte management, fluid resuscitation is initially with isotonic saline solution at 15 to 20 milliliters per kg per hour, which is roughly a 1,000 to 1,500 milliliters bolus in the first hour. The next 24 to 48 hours, the IV fluid rate and composition is adjusted according to CVP, urine output, blood glucose, and corrected sodium levels. It's important to check corrected sodium for hyperglycemia. If corrected serum sodium is greater than or equal to 135 ml per liter, 0.45% NaCl is used, and if corrected serum sodium lesser than 135 ml per liter, 0.9% NaCl is used. When glucose falls to 200 milligrams per deciliter or 300 milligrams per deciliter, a solution containing dextrose, like D5NS, is used. It's important to carefully monitor for signs of fluid overload during fluid resuscitation, especially in patients with comorbidities like CHF and CKD. Electrolyte repletion includes potassium, phosphorus, magnesium, and calcium. Potassium levels must be greater than or equal to 3.3 mg per liter before insulin therapy is initiated. If potassium level is lesser than 3.3 mg per liter, potassium should be repleted and the patient should be closely monitored for any adverse effects such as cardiac arrhythmias. Potassium replacement therapy can be administered orally or intravenously, depending on the severity of the deficiency and the patient's clinical condition. The preferred oral form of potassium replacement is potassium chloride, and it can be given in dosages of 20 to 40 mg per day in divided doses. Intravenous potassium replacement is typically reserved for critically ill patients or those with significant cardiac or renal impairment, and it is administered in dosages of 10 to 20 mg per hour. It is important to note that potassium replacement should be initiated and titrated carefully, as rapid administration of potassium can lead to hyperkalemia, which can be life-threatening. Additionally, patients with renal impairment may have difficulty excreting excess potassium, so their dosages should be adjusted accordingly. It is also important to note that other medications such as ACE inhibitors, potassium-sparing diuretics, and potassium-containing salt substitutes may affect potassium levels and should be considered when administering potassium replacement therapy. Regular monitoring of potassium levels is important to ensure that therapy is effective and to avoid potential complications. It's important to evaluate and monitor the patient based on these criteria and act accordingly to provide the best care possible. Don't be caught off guard on your rounds. Share this vid with other below average or average med students such as yourself to help them actually make a difference in patient care and excel.